Hi class, this is Professor Ella Bozic. This is your content for voiceover for cardiac that we have gone over this past week, and hope this helps you out a little bit. These are all the readings. Again, we're going to go through peripheral arterial disease, coronary artery disease, DVTs, angina, MIs, cardiac cath, PCI, meaning stenting, and cardiopulmonary arrest. Okay? So starting off, what is coronary artery disease? And I know you guys did a great job in class telling me what this is. So it's a blood vessel disorder, okay? So it's known as what you guys told me as atherosclerosis, and that old term is what? Hardening of the arteries, right? So we get these fatty deposits in our arteries, and they harden over time. So this is going to cause some issues with our body, okay? If we get hardening in our arteries, we're probably going to have some blood flow issues, right? So really, what is the largest effect coronary artery disease has on the body? Decreased perfusion. It's huge, okay? So our heart's trying to pump out blood, goes through our coronary arteries, but if we have a blockage of some sort or starting to have narrowing because of the fat buildup, we're probably not going to get that best perfusion to the rest of our body, okay? Will cardiac output be increased or decreased? Decreased for sure, okay? So we're not going to have the best cardiac output due to the narrowing or depending on how bad the fat deposits have built up or how bad the atherosclerosis is in the coronary artery, depending if it's, slightly narrowed, medium, totally occluded. Definitely cardiac output will be decreased. So the whole issue again for coronary artery disease, also known as CAD, is really the effect of the body's perfusion and how well can the body perfuse and what's causing these perfusion issues. So coronary artery disease, we'll get into this in a little bit, but it tends to evolve into more serious problems down the road, especially if it's not fixed right away or corrected right away. And we went over these in class, and we're going to get to these soon. But of course, stable angina or chest pain, and of course, leading to end stages, myocardial infarctions. And we'll get to all that. But that is serious problems that CAD can lead to. I don't want you guys to get too confused, though. I don't know if you remember we talked about cardiovascular disease, also known as CVD. That's kind of the umbrella term for a lot of coronary diseases. So cardiovascular disease is the leading cause of death in the world. And coronary artery disease is actually the most common type of cardiovascular disease under the cardiovascular disease. Okay, so again, CVD, cardiovascular disease, is that umbrella term, and coronary artery disease, CAD, falls under that. All right, we'll move on. So just a picture here, a good visual to show you, as you can see the top photo here in our coronary artery, blood's flowing freely, doesn't look like there's any fat deposits building up, I don't see any narrowing. Okay, this middle photo shows buildup of fat deposits in our coronary artery, and as you can see, blood flow becomes minimal. So our perfusion is decreased and cardiac output is decreased. And then the third photo down shows actually a complete occlusion, and it's actually showing red blood cells or platelets or white blood cells or whatever they may be. They like to stick to the fat, and they aggregate at the fat sites. So not only do we have a complete occlusion, we're actually building up a thrombus or a clot. So not anything good going on here. We have total decrease of blood flow. This actually is probably going to lead to a very severe myocardial infarction, probably a STEMI, known as a ST elevated MI. So some causes. So just kind of getting down to how does this plaque build up? Okay. So there's a thing actually called endothelial injury. And if you think about our coronary arteries and actually compare them to our skin layers, just like our skin, our arteries have layers. So there's the endothelium layer, okay, which is the innermost layer of the coronary artery. So when we have injury to the endothelium, and I want you to look at figure A, as you can see, there's like a little fissure there. It's like a cracked spot. It's damaged endothelium. So what causes this are actually what the bullet points are to the right of that image. Hypertension is a major cause, tobacco use, substance use, high cholesterol, diabetes is a big one, infections, toxins. These are all examples of things that can cause endothelial damage and inflammation in the coronary artery. So this plays a huge role in how plaque develops and builds up. And, an easy way for me to think about it is if you see that fissure or crack, it's actually a good spot for things to hide and form in, okay? I think I use in class just an example of like a sidewalk, and if there's a huge crack in a sidewalk, we also tend to see like a lot of dirt and debris kind of fall into that crack. Kind of same thought with this. It's an easy place for things to fall in. It's an easy place for things to get caught up in, okay? So again, the endothelium, it's that inner lining of the artery, the coronary artery wall, and an easy spot for fat deposits to collect. And going on, figure B, it just shows a more accumulation of the fat cells. Okay, they accumulate and migrate into the lining. And then figure C, we have more plaque buildup and our coronary artery is narrowing even more. And then figure D is actually pretty much complete occlusion, and that thrombus had formed, and it's very similar to that slide we looked at previous, where the blood cells aggregated at the fat and caused a clot, and this is what that's doing here and completely narrowing the coronary vessel. We also went over in class a measurement of inflammation, okay? And if we thought of, someone had said it starts with a C, it's a CRP, so C-reactive protein, and we typically do these with more inflammatory diseases. So if we think of lupus or rheumatoid arthritis or inflammatory bowel disease, we'll have an elevated, most likely elevated CRP. So we don't tend to just draw on CRP with cardiac diseases, okay? But just as a side note, because we're having damaged endothelium, and that damaged endothelium causes inflammation, we'll probably get an elevated CRP level. Again, it's not one of the things the doctors will recommend to order, just kind of an interesting thing to note on the side, that it will pick up the inflammation from the coronary vessel. And moving on from here. All right, so we talked about collateral circulation, kind of a pretty cool thing that our body does. So we have two factors that contribute to the growth of collateral circulation. So one factor is that it's inherited. So it's actually an inherited predisposition to develop new blood vessels. Okay, so this is what our body's doing. It's developing new blood vessels so it can better receive blood flow because of a blockage. So our body knows to do that, and it's pretty neat. So people have more of an inheritance than others. It just depends on that, okay? And another term for that is angiogenesis. Also, the presence of chronic ischemia. So chronic means over a long time, right? Acute is quick. So if there's more of a chronic issue where there's been a decreased perfusion, decreased cardiac output for quite some time, our body has kind of gotten used to that, and it has developed new blood vessels because of that, okay? So another term for that is chronic ischemia, chronic poor blood flow. So again, the plaque is blocking the normal blood flow, and it's happening over a long time. And this is how collateral circulation develops. So I think we answered our own question here. Who is more likely to develop collateral circulation? And that would be, of course, the slow onset. Rapid onset, our bodies wouldn't have as much time to auto-generate our blood cells as chronic, okay? So if we have more of an increased workflow, like if a patient starts to exercise, so collateral circulation helps them great at rest, right? Our body has gotten used to that decreased blood flow. We have a little bit of collateral circulation. We have a little bit of new vessels that grew to help perfuse the body a little bit better. But if we increase our workload and we start exercising, how do you think that affects our collateral circulation? It's really not going to help us out too much there. So the patient will probably start seeing some signs and symptoms of a blockage when there is increased workload of the body, increased exercise, all right? Whereas at rest, we probably won't feel those signs and symptoms of CAD as much. And here's just a photo of an example of collateral circulation. So figure A is showing, good blood flow. We don't have any blockages whatsoever. Figure B, we have a little fat buildup here, and it's narrowed our artery. And as you can see on the sides here, it's developed new blood vessels to get a little bit better blood flow to the rest of our body. And in figure C, we have a complete occlusion, and it's just showing you a little bit more buildup of blood vessels. So again, our bodies are quite amazing to even be able to do this. All right, so who's at risk? Okay, so we have our risk factors, and I know you did well with this in class. We have our non-modifiable risk factors, and you told me those are things that we can't change, okay? So our age, typically males 45 and above are at higher risk, women 55 and above are at higher risk. Gender, male tend to be higher risk for coronary artery disease. Ethnicity plays a role, and genetics. Modifiable, things that we can change, right? So high serum lipid levels, blood pressure levels, even over 120/80, diabetes, tobacco use, physical inactivity, obesity, substance use. Again, all things that we can educate our patient and change if they do have any of these things going on. We not might be able to change the non-modifiable, but we can sure help our patients change the modifiable risk factors. I want to get a little bit into cholesterol, okay, because it's pretty much a huge factor of what causes CAD. And I want you guys just to know these levels. So we have a total cholesterol level, and we want that ideal range to be less than 200. We have a borderline high of 200 to 239 and a high level of 240. Our LDLs. I've been thinking about clinical, I guess, ADLs. So no, LDLs. So we want that ideal range to be less than 130. A borderline high of 130 to 159, and a high level is 160 and higher. So we want low levels for LDLs. We'll get into this in a little bit. HDLs, we want them to be 50 and higher. A borderline high is 40 to 49, and a high is less than 40. Okay, so we want these to be high. And triglycerides should be less than 200. Borderline high is 200 to 399, and a high level is 400 and higher. So I really want a good focus on our LDLs and HDLs, really because a lot of our cholesterol medication actually has a huge focus of how it controls the LDL and HDLs. So what do the HDLs do? HDLs, they're the good cholesterol, right? So these guys, they contain more protein and they contain fewer fats, or also known as lipids. So they're a good cholesterol. And what these do is they actually carry the fat away from the arteries and they go to the liver to be metabolized. So that's why we want more HDLs. The more HDLs we have, the better, because we have more transport, okay? So if you're waiting at a bus stop and there's only one bus going through the bus stop every so often, do you think we'll have as many people getting transported today? Probably not, but if we have at least 5 buses going, we'll have a better chance for people to get transported. Kind of same thought with this. If we have more HDLs, it's going to carry more fats to the liver to become metabolized. So they actually prevent lipid accumulation with the arterial wall, okay? LDLs, we don't want these, right? They're our bad cholesterol. So they actually contain more fats. They have a major attraction to the arterial walls. So if you can remember this, LDLs love arterial walls. So L, love. HDLs, H, hate arterial walls. So maybe that can help you differentiate between the two of them. So high LDL levels mean that there's a lot of plaque going on, okay? And that's a concern. And triglycerides, they're the most common fat. But please just focus more on the LDLs and HDLs for me. Just a little talk about hypertension, because this is one of the things that causes major endothelial damage, right? So it causes those fissures in our coronary artery, which causes plaque buildup. So the stress of elevated blood pressure, again, causes endothelial damage. Also increases our risk for, of course, what we're talking about, CAD, also stroke, peripheral vascular disease, and heart failure. So if we have an increased rate of endothelial damage, what's at risk? Increased plaque buildup for sure. So we're going to have a fissure or crack in our endothelium, and we're going to have increased plaque buildup. So we're at huge risk for that if we have chronic hypertension. So normal blood pressure, what is actually our normal BP? 120 or less systolically and 80 or less diastolically. Okay. Elevated. Surprisingly, it's systolically of 120 to 129 and a diastolic reading of 80. Stage 1 is a systolic reading of 130 to 139 and a diastolic of 80 to 89. And then stage 2 is a systolic of 140 and above and a diastolic of 90 and above. How can we help patients control blood pressure? What can we do? What can we hopefully start off with first? Hopefully, maybe more lifestyle changes like losing some weight, getting some exercise, changing our diet a little bit. If we do have to add in medications, so be it. But I think it's great to start with, if we can change some lifestyles around, and it works from there, that's awesome. So if you think about it, why we have such high blood pressure if we do have coronary artery disease. So do you think there's more force needed to push blood flow if we're having more of like an occlusion in our coronary arteries? For sure. Okay, so our heart's working a little harder to push the blood through sclerotic arteries. It increases the force, right? So it's going to make our blood pressure high. So that's adding a lot of workload to the heart. So just another example of how the workload is added to the heart when we have plaque buildup and narrowing in our arteries. So what can we do as nurses? Okay, nursing care. So we want to pinpoint, hopefully early prognosis is best. So screening is key. Okay, so if we can get a nice thorough health history, what's their family history like? And family history is so important, especially with cardiac diseases. It really is so hereditary. So if you're doing like a little assessment and you're doing an interview and your patient says, well, my mother passed away at the age of 60 from a massive heart attack, and my father did as well actually at the age of 50, that's going to send a huge red flag, right? That they need to probably seek treatment a lot earlier than what we want to do, okay? So we want to make sure that any of their modifiable risk factors are under control. If there's anything else we can educate or offer the patient, the earliest as possible is the best that we can do. So early treatment is key, okay? Screening is key, especially with a family history, all right? So identify your high-risk patient. Are they having any symptoms? What could be some of their symptoms that they're presenting if they do have occlusion of their coronary vessels? They can have chest pain, okay? They can have high blood pressure, what we just talked about with the force of the heart trying to push more blood flow through. They can probably appear fatigued, dizzy, all right? What's their activity like? Okay, some questions to ask them. How often do you exercise a week? Okay, what's your work life like? Are you, is it a desk job? Are you moving around throughout the day? What is your diet like? Do they take in high amounts of salt, high amounts of saturated fats, cholesterol? How is their stress at home and at work? Do they smoke? So getting all of these, if we think about the modifiable risk factors, kind of interviewing them along those lines, okay? So what would we educate our patients with CAD, okay, who maybe are showing signs of CAD, who are presenting positive from their interview with you? We want to help them maintain an ideal body weight, and we can help them doing that through diet and exercise, right? What would we say for their diet? What would we recommend? Low salt, right? Low cholesterol, low saturated fats. We want the good fats, right? And help them teach the differences between bad fats and good fats. Some examples of good fats, avocado, salmon, are a few examples I can think of off the top of my head. If they're smoking, can we help them quit smoking? So we're just going to have a little pharmacology with, for coronary artery disease. And like I told you, cholesterol is a big deal with CAD because cholesterol is actually kind of helping, especially the LDLs with that buildup of fats. So I know everyone has heard of the statins before, and I think everyone in class actually raised their hand that they have given at least one of them in their clinical. So these are the HMG inhibitors or statins. So these are the ones I want you to know is atorvastatin or Lipitor, Pravastatin or Prevacol, rosuvastatin or Crestor, and simvastatin, also known as Zocor. Okay, so these are typically well tolerated with few side effects. They help lower triglyceride levels and they increase our good cholesterol levels. They increase our HDLs. And again, why is that so good to have an increase in HDLs? They attach to those fat deposits in our coronary arteries and they transport them to our liver to break down and metabolize, okay? So remember the bus, okay? Or I think in class I used an example of like a macrophage eating up bad bacteria. It's kind of like this, but it's eating up the bad fats. It's transporting the bad fats to the liver, okay? So it's helping get rid of our plaque buildup. With the Zocor, I do want you to know this. So if a Zocor is used with a fibric acid derivative, there can actually be an increased risk for rhabdomyolysis. And some examples of a fibric acid derivatives, Lopid, niacin, erythromycin. Okay, so just know that with Zocor. And again, the statins, they help block the synthesis of cholesterol. They increase the LDL receptors in the liver, which means we have better breakdown of the LDLs in the liver. Again, they help increase our HDLs. And these patients sometimes can have symptoms of a rash, some GI issues, nausea, vomiting, diarrhea. High liver enzymes, we want to watch our liver enzymes just because that we have that metabolism going on in the liver, and also the symptoms of rhabdomyolysis. So again, if a patient's having like extreme muscle weakness, they're presenting almost like in a dehydrated state, that would kind of cause a red flag for questionable rhabdomyolysis. So we would want to monitor liver enzymes and also a CK level, also known as a creatinine kinase. And that is actually what we really watch for if there's any rhabdomyolysis going on. Next on our pharmacology list is niacin or niaspan. So this is actually a water-soluble B vitamin, and it inhibits the secretion of LDL, so it blocks the bad cholesterol and it increases the good cholesterol, increases our HDLs. Just some things to know about niacin is it can cause some flushing about 30 minutes after you take this pill. And this flushing and itching can happen more so in the face and torso. So they say if a patient does go through this flushing and itching, 30 minutes after they take this medication. If you take an NSAID 30 minutes actually prior to the dose, it can prevent the flushing. Take drug with food, and again, we're watching the liver enzymes because we're having more metabolism of the bad cholesterol. Patients also can develop GI upset, again, nausea, vomiting, diarrhea, and we want to watch for orthostatic hypotension with the niacin. And moving on to the fibric acid derivatives that we talked about, the ones I want you to know are Tricor or fenofibrate and Lopid, gemfibrozil. Again, it's decreasing our bad cholesterol, our LDLs, and it's increasing our good cholesterol, the HDLs. Kind of similar symptoms, if any. They can develop a rash and mild GI upset. And just be aware that this drug may increase the effects of Coumadin and some antihyperglycemics. So patients can be in an increased risk for bleeding if they take Coumadin along with one of these medications, or if they take an antihyperglycemic along with one of these medications, they may become hypoglycemic. So we want to watch out for that. And then antiplatelets are really important with CAD. So aspirin is a very typical medication providers will put patients on who are either at risk for CAD or who have CAD. It's a low dose by mouth, 81 milligrams, and also Plavix is also recommended. Typically, if a patient, isn't able to take aspirin, maybe they can take Plavix instead. Of course, we want to make sure that our patients aren't at high risk for bleeding if they've had a recent stroke or head bleed or GI bleed or trauma. We just want to be careful with giving this medication for patients for increased risk of bleeding. Okay, that was coronary artery disease. So we are moving on to peripheral arterial disease. So we talked about coronaries in our heart. So the arteries that are within our heart. Now we are moving on to peripheral arterial disease. So think of our peripherals, right? Very similar thoughts, though, with these diseases. A lot of things you may find as a repeat a little bit because they're such similar aspects of the disease, just in different areas of their body. So we have thickening of the arterial walls, okay, again, but this is in the peripheries, and we know thickening leads to progressive narrowing, meaning we have decreased blood flow, decreased perfusion, decreased cardiac output, okay, and you're going to hear me say this so often. This can be, in the upper or lower extremities. And when does the prevalence of peripheral vascular disease or peripheral arterial disease increase? The most common is age, okay? So we see patients tend to become symptomatic between the ages of 50 and 70 years, especially with a history of coronary vascular disease or coronary artery disease. We typically see peripheral arterial disease happen as a later stage of actually coronary artery disease. This is actually a marker of an advanced systemic atherosclerosis, okay? So it's more of an advanced disease. What disease might you see this occurring earlier? And I know in class some of you said diabetes, and you were correct with this. So diabetes is actually a disease that we see peripheral arterial disease occur in earlier. And what is the leading cause of peripheral arterial disease? You guys know this, and it's plaque buildup. It's atherosclerosis, okay? And so think of some other risk factors, and we just went over a bunch of these. Very similar to CAD, so think of things that had caused endothelial damage. So we have hypertension, high cholesterol, tobacco, age, obesity, diabetes, okay? All very similar to CAD. Typically we see in peripheral arterial disease It affects some segments of, we see the carotid arteries, and more so in the lower extremities than anything. And just an example, I'm just going to go over the most common areas we see peripheral arterial disease affect. And we have our iliac artery. So if you see kind of more, lower abdomen area, we have our common iliac artery. We have our femoral arteries, popliteal, more down by the knee. Tibial is by our shin. Perineal, again, is by the shin. And those are the most common sites. Okay, so again, iliac, femoral, popliteal, tibial, and perineal. You told me this in class, but really what's the most common site, especially non-diabetics, that we see blockages? Femoral popliteal. So we hear a lot of surgical procedures, as we call it, a fempop bypass, femoral popliteal, and we see this with a lot of patients. Diabetics actually tend to develop diseases below the level of the knee. So we're going to be looking at more of the perineal artery, okay, and tibial artery with diabetics. So signs and symptoms of PAD. So we have a little bit more pain with PAD, okay? Coronary artery disease, okay, yeah, we'll probably typically develop chest pain, and hopefully not, but may lead to MIs. But peripheral arterial disease is we have a lot of pain in our extremities, okay? And the first type of sign and symptom that we're going to go over is intermittent claudication. So this is a very classic symptom of PAD, and it's actually muscle pain caused by exercise, and this resolves with rest. And this is due to ischemia. Okay, so we're not getting that proper blood flow or oxygen to our certain extremity, whether it be one or both, depending on the blockage. But when we have increased workload or increased exercise, we're going to have a lot of pain below the level of that narrowing, okay? So again, the severity depends on the site, and the severity depends on how big the blockage is. And do we have that collateral circulation? Okay, so that's also something to think about too. So if it's more of a chronic issue, or the patient is actually predisposed to that autogenesis, we might not have as much pain due to the collateral circulation. But a lot of these patients with PAD will have that huge onset of pain when they exercise. So again, ischemic pain, it's really the buildup when we don't have that proper oxygen or blood flow to our area. We can have that buildup of lactic acid. Okay, so I know you guys even feel this too. If we're exercising, we have that kind of burst of pain in our muscles, right? It gets a little burning and then it goes away. Okay, it takes some time right at the beginning when we exercise, we feel the burning, and then we kind of get used to it a little bit. So that's actually lactic acid forming, and the feeling to them is actually kind of the same, but their pain resolves with rest. Once the patient stops exercising, that lactic acid will clear and the pain subsides. Because they're not needing as much blood flow to the area, right? They're not needing as much blood flow and oxygen, so the pain is going to start to subside. If you think about it, our iliac arteries, remember those were kind of lower abdomen area. If we have a blockage in the iliac arteries, where do you think our pain will be? It's going to be lower. So patients who present with more buttock and thigh pain probably, typically have a blockage above, and, gives providers a good knowledge base of where the blockage may be depending on the pain location of the patient. And if we're having more femoral or popliteal, if we're having a femoral or popliteal blockage, where is our pain going to present? Lower, right? So it's probably going to present in the patient's calf. So the pain presents lower of the blockage. Some, the symptoms that go along with intermittent claudication or just pain in general that they're having, they can feel a burning sensation to the extremity. It can feel heavy, pressure, soreness, tightness, weakness, and even some numbness or tingling. Another sign and symptom I want to mention is the paresthesia, so numbness and tingling of the extremity. Patients can really feel this in their toes or feet, and this actually is from nerve tissue ischemia. So think about it. We have a blockage somewhere, depending on the location, and that blockage is actually causing ischemia to the nerve tissue. So we're not getting enough blood and oxygen to our nerve tissue. So it's actually, gradual reduced blood flow to the neurons. And that's going to cause a lot of pressure and deep sensation issues with the patient. So just a question, if a patient does have this paresthesia going on, do you think these patients are going to notice lower extremity injuries? So if they have a burn or they stub their toe or drag their foot on something, probably not as much. They're not going to have as good sensation. I don't want to compare this to, it's a little similar to peripheral neuropathy. It's not the same thing, but I guess we can say it's a little similar to the effect that we don't have as much awareness to the extremity because of the decreased sensation. Think about temperature too, cold, hot. We're not going to have the best sensation for that. So we need, as nurses, we need to do a lot of education, and we'll get to that just on how to manage this. And then critical limb ischemia. So this is actually more of a later stage issue with PAD patients. So as peripheral arterial disease progresses, patients develop pain at rest. So not just intermittent. So remember we talked about intermittent claudication. We have major pain with exercise, and at rest it gets a little bit better. This is all the time, okay? Most often it's seen in the feet and toes. And we're going to go through a lot of signs and symptoms, but we notice that the pain gets a lot worse with elevation. Okay, so if we elevate, think about we're elevating our extremities. It's really, it's not helping get the blood flow to the area if we elevate, right? If we lower our legs, that gravity is going to help us a little bit, and it's going to try to bring some blood flow and oxygen to the area that's screaming for oxygen, right? So this is what's happening. We're not getting enough oxygen and blood to the area because of the blockage. So our extremities are they're screaming for blood flow, and it's pain. Okay, it's a lot of pain. So our extremities are not receiving the proper blood flow, and this is what's happening. And again, this is a later stage. So it's chronic ischemic rest pain lasting more than 2 weeks. So if we see patients with PAD having that chronic pain and it's not getting better with rest, we're looking more for the critical limb ischemia issue. We can also, patients develop the non-healing arterial ulcers by this stage. They can develop gangrene. Patients with diabetes, heart failure, or even have a risk of stroke have an increased risk for critical limb ischemia. Okay. So we find that rest pain actually occurs often at night. And why do we think that? So the first one is kind of obvious. So you lay down at night, right? You go to sleep, you're laying down in bed. So patients will be typically laying down, they have their legs elevated, and that's going to cause a lot of pain because we don't have the help of the gravity helping bring the blood flow and oxygen down to our area. Okay, so it's elevation because we're laying down in bed. And we tend to, anyone, whether they have PAD or not, while we sleep, our cardiac output actually decreases a little bit while we sleep. So that decreased cardiac output while we sleep doesn't help us out any, especially with patients with PAD. They get even more of a decreased blood flow. Okay, so they're going to have increased pain there as well. We do see a lot of patients with peripheral arterial disease tend to sleep in recliners, so their legs can be in that dependent position and be dangling instead of having their legs elevated. Complications of peripheral arterial disease. So, we especially see complications in patients with diabetes. We have to be very, very careful, okay? So, prolonged ischemia can lead to atrophy of the skin and actually the underlying muscles of the extremities. So that's a problem. Okay, so we begin to see atrophy. We can have actually minor trauma that can cause, larger wounds. We can have delayed wound healing. And think about diabetics, especially in diabetics. Um, we can have increased wound infections, delayed wound healing. So if we have patients that are stubbing their toes, they're having blisters from improper shoe fitting, temperature control, they can't feel the burning sensation or extreme cold. That's a major issue, and we can have trauma occur to our extremities because of it. So a big part of, nursing education is helping patients, do they have, proper footwear? Does it fit comfortably? How about socks? Are we going to have rubbing? Are they going to be able to feel the rubbing? We do not want blisters forming, okay? Temperature control. We need major education on temperature control. Maybe feeling with another extremity first that has proper sensation before putting the extremity, somewhere that we cannot feel the sensation. Again, diabetics is we really, really need to do proper education and watch out for the diabetics with the large wounds, the delayed wound healing, wound infections. Arterial ulcers are a complication of PAD, and they specifically can occur over bony prominences. Non-healing. Okay, we typically have a major issue if we don't have proper blood flow sustained. So if we don't fix this issue, they're probably not going to heal. So we need oxygen for healing, right? Oxygen, blood flow for healing. And if we still have the strictures or narrowing in our arteries, it's never going to be fixed. Our later stage is gangrene. Unfortunately, that can lead to a lot of amputations. Osteomyelitis, we can get an infection down even into the bone. Okay, and that can be an issue also for a possible amputation. So again, if adequate blood flow is not restored, or if an infection cannot be controlled, we can run into issues of a patient needing an amputation. Okay. If we're talking about collateral circulation, it can help with some of these complications, but probably to a certain extent. Okay. Just some photos of an example of arterial ulcers forming. Again, for the most part, it looks like, on the toes, bony prominences, the ankle bone. So what are our patients going to appear like, especially in their extremities, if they have peripheral arterial disease? Their skin becomes, very thin, okay? We get thinning of the skin. Remember we talked about atrophy of our skin and muscles due to the decreased blood flow and oxygen? Their skin gets thin. We have pale blue color to our extremities. The skin becomes kind of shiny and taut. Our lower extremities usually lose hair. It can be an upper or lower, but we typically have hair loss, and they're very cold to the touch. We may see non-healing wounds. Do you think we'll have pulses, or they may be very distant pulses? They may be hard to feel. They may be thready. They may be absent. Okay, so we can be decreased to absent in our pedal pulses, popliteal, femoral. Okay, and especially patients who have a history of PAD or have a diagnosis of PAD, it's important to check all these places. So femoral pulses, popliteal, pedal. Okay, so as we go down the leg, it's still important to check every aspect of the leg for pulses. It can actually help us determine too where there might be a blockage. So we're going to talk a little bit about this, and I have a photo, I think, in the next slide, but a major sign of peripheral arterial disease is actually elevated pallor. So it's when our leg is elevated, it completely blanches and becomes pale, okay? And we also have dependent rubor. So when a patient dangles their legs and they become in the more the dependent position, they become bright, bright, bright red. Okay, so it's also known as reactive hyperemia. Also, redness of the foot occurs when the leg is in the dependent position. When we elevate our leg, it becomes blanched and a pale looking color. And Here we are in the next slide with this example of an elevated pallor and a dependent rubor. And I know we talked about why does the redness occurs. So it's actually the cause of gravity. We don't have the expansion of the arterioles with the blood. I do want you to know this slide. So I know we haven't gotten into venous at all, but they're very opposite. Some people think that, you know, venous insufficiency or venous blockages are very similar to arterial, and they're not. So I really want you to know the differences between peripheral arterial disease and any venous disease going on. So for PAD, we're going to see a capillary refill of more than 3 seconds, okay, and that's an issue, and that's a decreased blood perfusion. Whereas in venous stasis or, you know, venous insufficiency, we still have pretty good cap refill going on. Dermatitis, or it's like an inflammation of our skin, is very rare, whereas in venous, dermatitis is very common. Edema is absent for arterial, but we do have large amounts of edema for venous. Hair loss for arterial, hair is typically present with venous. We see thickened nails, okay, with arterial. Normal nails still develop with venous. We have that intermittent claudication or rest, or even pain at rest with arterial. Venous is just a constant dull ache or heaviness in the calf. Very similar almost to like a clot. We'll talk about DVTs in a little bit, but a lot of these venous issues are actually very similar to how a patient presents with a blood clot in our peripheral area. We're going to have decreased or absent peripheral pulses for arterial. We won't have that issue with venous. The peripheral pulses will be present. We'll notice that dependent rubor or elevated pallor for arterial. In venous, they just always have this bronze brown pigmentation. The skin will be cool for arterial. Venous, the skin will be warm. And then the skin is thin and shiny and taut for arterial, where venous is the skin becomes thick and hardened. And some diagnostic tests, I should say, for peripheral arterial disease is we have the venous duplex ultrasound, okay? And some of you, I think, have seen this in clinical. So it's an ultrasound, and it actually helps map the blood flow through an entire region of an artery, okay? So this can determine the degree of blood flow, and it can help us, you know, pinpoint as to where the blockage is. And then another diagnostic test that we can use is actually segmental blood pressures. So with using a Doppler, we get a blood pressure at the thigh, below the knee, and at the ankle level. And if we see a drop that's greater than 30 systolically, and you know, from moving from each area as you move down the leg, we're pretty positive for a blockage for a PAD going on. And then we have the ankle brachial index. So this is done, and I'm going to go to the next slide just you can have a better visual of the ABI. So ankle brachial index, also known as ABI, is a value that you get. You need to get a ankle systolic blood pressure and an arm systolic blood pressure. So we're going to get that ankle systolic first, just like that photo is showing, and that's by Doppler. So we're going to get that ankle systolic, and we're going to write that down. And then we need to get both brachial pressures. So a blood pressure in each arm, and we're going to take the highest out of the two. Okay, so say I am 130 systolically in my right, and I am 126 systolically in my left. I'm going to take my right. So we're going to use my right arm as a 130. So that's going to be our bottom number, okay? So you're going to divide the ankle systolic by the highest arm systolic, and you're going to get a severity level, okay? And this is our scale. This is our ABI scale used to rate our peripheral arterial disease severity. And you can fall under a severe, moderate, mild, normal, or poorly compressible, really meaning that we really probably can't even get a reading. So I really just want you to pay attention at least to the normal, mild, moderate, and severe, okay? So I do want you to know this slide. I want you to know the values of the ranges, and that is that. So we're going to move on. So treatment and care, okay? So we're nurses. What can we help change for our patient's lifestyle? What can we educate? And I know you guys have told me this a lot in class. So we're going to talk about diet, right? So we're going to help educate proper diet, decrease saturated fats, decrease sodium, decrease cholesterol. If they're smoking, we can help get them on a smoking cessation program, helping them get on an exercise program, reaching their ideal body weight. If they need drug therapy, helping them, take their drug therapy, educate them about what drugs they have been placed on. If they are diabetic, we really need to run tight glucose control. Oh, it's so important. Blood pressure control is important, whether it's just lifestyle changes or if medication is needed. Cholesterol control, again, with possible medication or diet. So these lifestyle changes really can help, they're very similar to coronary artery disease. And we're just going to go into a little bit more pharm with peripheral arterial disease. So I want you to know these two, they're known as ACE inhibitors, and I know you guys remember the ACE inhibitors, so angiotensin converting enzymes. So these reduce, first of all, they actually reduce the symptoms of peripheral arterial disease. And the one I want you to know is ramipril or Altase. So remember the prils, this is the one I want you to know. Antiplatelet therapy, very important. So again, it's either a low-dose aspirin or placed on Plavix. Some patients cannot take aspirin, and they may be able to take Plavix. So it's kind of patient-dependent as well. Coumadin is not recommended in patients for peripheral arterial disease. Coumadin is actually an anticoagulant. It's on an antiplatelet. So they recommend not adding an anticoagulant along with an antiplatelet. It's really not going to help our heart out anymore, and it can cause an increased risk for bleeding more than anything. So it's just a higher risk, and that's why it's not recommended. There's also some treatment for intermittent claudication, so remember the pain. So we have treatment for the pain of PAD. So cilostazol, okay, this helps inhibit platelet aggregation. It increases vasodilation. So it's going to decrease the risk of any clotting, and it's going to open up our arteries just a little bit better for blood to flow through. And of course, if we're getting a little bit better blood flow and oxygen, we're going to have decreased pain. This is not recommended for patients with heart failure. The other one I want you to know is patoxyphilin, and this one improves the flexibility of red blood cells. Okay, so it's helping, it's kind of thinning out the red blood cells a little bit, and it's helping the blood flow a little bit better. Again, getting the blood flow and oxygen to the area needed to decrease pain. And it does kind of the similar thing as cilostazol. It will help inhibit platelet adhesion, so helps with clots again. So talking about the patient with the critical limb ischemia, okay, so remember, this is a later stage of PAD. This is when they're in pain all the time. So hopefully if the patient is a candidate, we need to do revascularization. So the patient is in dire need of just blood flow and oxygen to the area, and we typically do this by surgery, okay? So a bypass surgery can be done, all right? Remember, we talked about a very typical surgical procedure called a FEMPOP bypass, so femoral to popliteal, okay? And remember that bypass is just taking another route. So it's taking, they can use an autogenous vein or a native vein from a patient and, you know, reroute the blood flow around the blockage. Okay. So it's just remapping the area. We also have percutaneous transluminal angioplasty, also known as PTA. So this is when a catheter is actually moved into the area of the occlusion where the fatty deposit is, and a balloon goes in via the catheter, and the balloon blows up the area, and it pushes the fat deposits away, the atherosclerotic plaque. I know typically nowadays we tend to see a stent placed just to help with the blood flow and to help with any further buildup of plaque. I know there is some videos that show just the widening of the artery using the balloon, and the procedure is done. I know we more so see a stent place than anything. If they're going in and they're gonna, you know, if they're gonna take the time to do this, I would think they would place a stent, just so this doesn't build up again on the patient. There are some patients who may need to be just treated conservatively, especially if we're thinking about maybe age or comorbidities. So there's a lot of things affecting on why the patient would not be a candidate. But there's some things that we can do as nurses to still help treat these patients. So again, we're protecting the extremity from any trauma. So again, that's the education again, right? On, you know, temperatures, hot, cold, proper footwear, proper socks, helping the patient continue with optimal drug therapy, such as blood pressure control, antiplatelets. I know this says anticoagulation here, and if you want to cross this out and put antiplatelet so you don't get confused, please do so. Blood pressure control, cholesterol control. Helping decrease the ischemic pain, so getting pain medication, maybe using those medications for the intermittent claudication pain. Prevent and control any infection, especially if there's open wounds to the area. Meticulous skin and foot care. Wound care, again, avoiding hot and cold extremes, encouraging roomy shoes, and providing protective footwear. We typically see patients, you know, about 50% of patients with critical limb ischemia have a pretty high mortality rate. They pass away within 5 years. And these were some videos we watched in class about revascularization. We had watched a bypass. We had watched PTA. Sometimes patients, if we're talking about bypass again, yes, we did say an autogenous vein or a vein from the patient's body. Sometimes there are synthetic veins used as well. Mixing of both autogenous and synthetic. And then this is just more procedures that can be done to help fix the blockages for patients with PAD. So this is just showing us what a stent is, and it's really an expandable metallic device, again placed by the catheter. And once the catheter is released, this stent opens up, and it helps prevent any stricture of the artery and helps blood flow. Arthrectomy, so it's actually removal of the obstructing plaque. So we typically see this, but it can be used either by, I know this video is going to show like a blade-like type of maneuver where a blade goes back and forth and takes away the plaque, or a drill-like maneuver where it's going in a very fast circular motion along the plaque, and it's degrading the plaque up into little bitty pieces that the body can absorb. Cryoplasty, it's actually what we watch with PTA. So they go in with the catheter, they use the balloon, and then they use the nitrous oxide for cooled. So they're saying the cooling actually helps limit any restenosis and kills off the fatty deposits. They might put a stent in after they use the cooling therapy. And then an endarterectomy. So it's actually going in and surgically removing the plaque itself. So they go into the artery, they make an incision, and they remove the plaque, and they typically put like a patch graft over the area that they made the incision. I know this video shows an example. We see a lot of examples of a carotid endarterectomy. Those are the most common procedures used for this. Unfortunately, again, if we cannot get the proper perfusion or blood flow to the area, our tissue will continue to die. We'll see gangrene. We may have osteomyelitis develop, and we may, that's where the amputation comes in. So nursing, okay, what is our assessment? So what are we doing first? We're getting that good pertinent health history, right? What's pertinent? What do we want to know about the patient? Their lifestyle. Do they smoke? Do they have diabetes? Do they have high blood pressure? Do they have high cholesterol? How's their exercise like? What's their diet like? What do we assess? Okay, so we did our health history. What are we looking at with the patient? What does their extremities look like? How is their skin? Is it cool to the touch? Is it warm? Okay. Do they have pulses? Are they distant? Are they decreased? Are they absent? Are they palpable? Can we at least get them with a Doppler? Is there any hair loss? Is the skin, taut? Is it pale? Are our toenails thickened? Is it cool, shiny skin? Do we notice some arterial ulcers going on? How's our capillary refill? How's the patient's sensation and mobility? Okay, so again, we're looking at the skin, we're looking at the temperature, the color. Is there any non-healing wounds? How do the pulses feel? Is there capillary refill? Do they have numbness and tingling? Teaching proper foot care and injury prevention. Pain management, okay, we can't forget to think about that. And if our patient's gone to surgery, so say they have gone down for some revascularization procedure, okay, what do we need to know? So what would be our priority care once we receive the patient back? So we need to do some vital signs, right? So we're checking the vital signs of the patient. We're getting those post-op vital signs. So we need to get those Q15s for the 1 hour, right? So we're getting 4 Q15s. We're getting 2 half-an-hour ones. And we're getting 4 hourlies, okay? We're checking the operative extremity, right? So what are we checking the extremity for? Bleeding, right? So, especially the site, if they've gone through the femoral artery, how's the dressing look? Is there a pressure dressing on there? Is there any bleeding coming from the dressing? Do we have a hematoma that developed or bruising that we want to keep an eye on? We're assessing the extremity for color, right? Did the color come back a little bit to the patient? Is it starting to warm up a little bit? Is it less cool? Do we have some pulses back? What's really important is getting that, we're going to get that report from the PACU nurse, right? So the nurse that, cared for the patient right after surgery. And did they tell us, is there a pulse back? Is it palpable or is it Doppler? Okay, we want to make sure that we still have these findings. So if the patient comes to us and we were told that we can use the Doppler, okay, we can hear the pulse with a Doppler, and then we're not hearing anything when they come to us. That's a call to the doctor immediately, okay? So somewhere within the line between talking to that nurse and doing your assessment, there's been a decrease of pulses again, and that's an emergency, okay? So the provider needs to know any changes from the baseline after surgery. How's their sensation? Is their capillary refill a little bit better? Do we want to place a patient in any position where the knees and hips are flexed for a while? we probably don't. We're going to have an increased risk of probably bleeding, first of all, and then an increased risk for clotting. Okay, so we do not want any flexion going on for a long time. So, not super supine, but in a more comfortable position where they're not in a flex position. Still turning and repositioning the patient, placing the pillow for support, and supporting the incision site. Definitely post-op day 1, they really should be getting out of bed. We need to get these patients up as soon as we can to ambulate. We know that helps prevent pneumonia and even blood clots from forming. We don't want increased sitting either, right? So that's placing our patient in a flex position, again, increased sitting. Places stress on the surgical site. It puts patient, again, at risk for bleeding and clots. So if we see a dramatic increase of pain and loss of pulse, what do we want to be aware of with this? May have some compartment syndrome going on. Okay, so just another thing to look out for: dramatic increase in pain and a loss of pulse along with that typically signifies that they may be having a compartment syndrome going on. Again, pain management. Should we be doing a postoperative ABI? So getting that brachial index, ankle brachial index, excuse me. No. Okay, we really should not be doing any compression of the operative leg or extremity at all. It's going to put a patient at huge risk for a thrombosis. So moving on to DVTs, what is a DVT? And you guys told me this in class. It's a formation of a blood clot within a vein. So now we're talking about veins. We're going from arteries to veins. And they're located, we're going to go over kind of 2 locations. We're going to talk about a little bit about superior or superficial superficial clots. And then we're going to talk more about deeper clots, DVTs. Deep veins are typically more likely located in like the common iliac or femoral veins. And then superficial, like an example is like a greater or lesser saphenous vein is a good example of superficial. So veins that are more superficial to the skin, deep veins are deeper within our body. So risk factors for clots in general: increased age, pregnancy, obesity, cancer, recent fractures, estrogen therapy, long distance travel, or, immobility. So I want you guys to know this slide. This is the Virchow's triad. So it's really how a DVT forms, okay? So when these happen in whatever state is going on with the patient, the platelets will aggregate, okay? The platelets are, whether it's a hypercoagulable state, a vascular wall injury state, or a circulatory stasis. Whatever of the 3 is going on, we have platelet adhesion and aggregation. So hypercoagulable state, so examples of some issues with this is, malignancy from cancer, pregnancy and peripartum periods, estrogen therapy, trauma, surgery to the lower extremities, can be hips, abdomen, or pelvis, inflammatory bowel disease, nephrotic syndrome, sepsis, and thrombophilia. Moving down to vascular wall injury, trauma or surgery, venipunctures, chemical irritations, heart valve diseases or replacements, because we can have vegetation going on, and vegetation, increases our risk for clots. Arthrosclerosis and indwelling catheters. Let's see. And again, indwelling catheters are like central line catheters, not like our urinary catheter. And circulatory stasis, atrial fibrillation. This is a very common one. You're going to go over this within the next week for your heart rhythms. But atrial fibrillation, atrial flutter is a type of rhythm that can go really, really fast, and then it can slow down, and then it gets really fast, and then it slows down. So this fast and slow creates pooling in the heart. And we know pooling of blood is not a good thing, right? Because when our blood pools, it creates clotting. So think about when our heart slows down a little bit and it pools, and then it speeds up. What do you think it's going to do to that pooled, clotted blood? It's going to push that clot right out, okay, into our circulatory system. And that's what throws those clots, okay? We'll learn more about that when you get to the rhythms. Left ventricular dysfunction is another example, immobility or paralysis, venous insufficiency or varicose veins, and venous obstruction could be from a tumor, obesity, or pregnancy. This is just a nice video showing a formation of a DVT. And then we have we're going to just break it up a little bit between superficial and deep. So just some clinical symptoms of superficial veins. Our vein becomes more like palpable and firm and cord-like. So when we press down on a vein, especially if you're like going to take some blood or put in an IV, we want it to be very like a trampoline. We want it to compress and pop back up on us. We'll be able to palpate these veins, but it's going to be very firm. It's not going to be compressible. It's not going to be trampoline-like. It's just going to be like cord-like and hard. The area around the vein may be itchy, painful to touch, reddened, and warm. We'll see a little bit of white blood cell elevation because we're having inflammation going on. Okay, so it's our body's reaction to elevate white blood cells as an inflammatory response. Again, same thought with elevated temperature. It's an inflammatory response. Also, our patient can develop extremity edema and extremity cramping. And then moving on to the deep veins. So clinical symptoms of a DVT. We typically see a lot of these in our lower limbs. We can see unilateral leg edema, so it'll be one extremity typically. Sometimes we have clots in both legs, but typically it's unilateral. Pain at the site, tenderness on palpation. Our superficial veins will look dilated. The patient will feel a sense of like fullness, depending on the site, whether it be a calf, the thigh. Again, we're talking about more of the lower extremities. This is where DVTs happen. The skin will be reddened and warm. We can have again a systemic temp of above 100.4. Again, it's an inflammatory response. If we have inferior vena cava involvement, we can see bilateral leg edema and cyanosis. The most serious complication of a DVT is, you guys know this, it's a PE. And we talked a lot about PEs in the last content. So post-thrombotic syndrome. Okay, so this is from chronic venous hypertension. It's really caused by a chronic vein wall injury from damage, persistent venous obstruction. Okay, so it's a chronic clot. Okay, results from chronic inflammation, chronic venous hypertension, chronic wall injury, and chronic damage. So we'll see signs of post-thrombotic syndrome begin within a few months to probably a year of having a DVT. Okay, so the patient will begin to develop pain, achiness, heaviness. They'll feel a sensation of swelling. They'll feel bursting pain with exercise, tingling. They can have persistent edema and spider veins, and they may start to see some venous ulceration. So we want to diagnose a DVT. Okay, so just talking about some blood tests. Yeah, do they diagnose it? No, but can they help with diagnosis? For sure. So we can look at a PTT level, so that'll be partial thromboblastin time. We can look at an INR level, international normalized ratio. We can look at H&H's from our CBC, so hemoglobin and hematocrit, platelet counts, D-dimers are pretty important. High results are, suggested of a clot. Our normal range for D-dimers are less than 250. Remember, it's picking up the fibrin strands from the degradation of the clot. That's how we see high results of a D-dimer. And also the fibrin monomer complex. Our normal range for that is below 6.1. Okay, so really know the D-dimer and the fibrin monomer complex, please, for this. Our most common diagnostic for a DVT is actually a venous duplex ultrasound, kind of very similar to how maybe they may look for blockages using a ultrasound for PAD. But for this, we're going to hopefully pick up a clot. So what we're doing is we're assessing for blood flow, and if we're having decreased blood flow below a certain level, we can hopefully visualize this on ultrasound. It helps us see if there's any filling defects, and again, it's helping us determine the location and extent of the clot. And it's really the most widely used test is the venous duplex ultrasound. Along with that, they can do like a compressibility test. So they'll press down a little bit on the veins, and we'll see if they collapse with application or external pressure. If it's abnormal, if there's a clot there, they will not collapse. Remember we talked about that trampoline effect, and we want them to be more of like a trampoline than anything. They will not be with this test, okay? And that will be a positive test. Just going back to this fibrin monomer complex, I did forget to mention that what this is that it's thrombin exceeds antithrombin. Okay, that's what it's picking up. Again, just know more of your D-dimer and fibrin monomer complex and the values for these. So treatment for blood clots. Okay, so we're going to talk about our PO medication first. It's our vitamin K antagonist, which is Coumadin or warfarin. Very common medication given to many patients. And what is the lab value used to monitor therapeutic levels of Coumadin? And that would be your INR. Typically, when we start Coumadin, it'll take effect within 48 to 72 hours. We want to make sure that our patient takes it at the same time every day. What foods do we stay away from? It's going to be foods high in vitamin K, so especially those green leafy vegetables. And what is the antidote for this? It can either be Kcentra or fresh frozen plasma. And then we move down to our thrombin inhibitors, and they're both very common. So we have our low molecular weight heparin, also known as enoxaparin or Lovenox. It's a sub-Q injection. There is not routine coagulations for this like we do for Coumadin. So Coumadin we do, if the patient's at home, we'll do a weekly INR with them. If they're in the hospital, it's typically daily. But for Lovenox, routine coags are typically not needed. Yes, we can monitor our CBCs, especially our hemoglobin and hematocrit, just to make sure that we're not bleeding anywhere internally. But other than that, we don't typically do routine coags. For the sub-Q injection, we want just to make sure to rotate sites, and we don't want to expel that air bubble out of that pre-filled syringe. Just remember that air bubble acts as kind of like a patch once injection is finished. Do not rub the site after injection. And what is your antidote for Lovenox? That would be protamine sulfate. Okay. And then we go on to our unfractionized heparin, it could be heparin sub-Q or IV. Typically, we'll see an IV drip of heparin for blood clots. That's kind of like your first acute type of treatment. And then we bridge typically to a sub-Q, like a sub-Q heparin or Lovenox. And then from there, we'll bridge to a Coumadin. And we know this by either doing more ultrasounds, looking at how the clot has broken down. Is the clot getting smaller? Can we move to sub-Q? So the provider will, make sure to look at therapeutic levels of medication, when we can change from IV to sub-Q to PO, okay? Labs to monitor heparin. That's going to be PTT. Yeah, PTT is important for IV or sub-Q heparin. And the antidote for that, again, is protamine sulfate, same as Lovenox. We do want to be careful. Side effects of heparin is HIT, HITT, heparin-induced thrombocytopenia. It's actually an immune reaction the body, has to heparin, and it's actually a severe sudden reduction in platelets. So what we need to do is we need to immediately stop the heparin. That's what helps the treatment of HIT. We just stop the heparin, okay? We may need to give an antidote depending on the level of heparin if they're in untherapeutic range, but typically we just stop the heparin. And then we're moving on to the factor XA inhibitors, also known as, I'm sure you've heard of these as Eliquis and Xarelto. For these, routine coag tests are not needed like Coumadin does. So a lot of patients who are kind of have more of a busy lifestyle, I should say, or tend to be put on this medication. These may cause thrombocytopenia. Again, routine coag tests are not needed. They do now have an antidote. Before, when these were newer, there was no antidote before. And, especially for patients who were at high fall risk, these weren't the best to be giving patients. So high risk falls would be put on Coumadin because at least it had an antidote if they were to fall and hit their head. But these do have an antidote now. It's called Andexxa, Andexxa. And we went over the heparin protocol in class. So it's really just a way of how you monitor your heparin, especially if you're on a heparin drip. So remember, it's a weight-based heparin. And once you set up your drip and start your drip, we want to draw that PTT level 6 hours. So we're drawing that PTT level every 6 hours. And depending on which range it comes back at on that heparin drip, we either have to increase or decrease our drip or do a bolus. Okay, some is both. Sometimes we have to do a bolus and increase the drip. Sometimes we just have to decrease the drip. So you just have to follow that protocol and where you fall in the range for the PTTs. Okay? And then there's surgical therapies. So we talked about an open venous thrombectomy. So that's actually removal of a clot through a vein by an incision. Okay? Catheter direct administration sometimes can be given. So for this as well, sometimes they can use an anticoagulation. So they can administer a thrombolytic drug, can dissolve the clots, and then, remove the clot from there. So there's a video for that. And then we talked a little bit, even when we were talking about PEs, about a vena cava filter or IVC filter, also known as a Greenfield filter, also trapeze. So this goes through, typically the right, see these more so in the carotids, into the jugular. And it's placed by a catheter. And then once the catheter is released, this little, I call it like an umbrella, it opens up and it's going to collect any clots coming from our peripheral sites. And, we make sure that they do not go into our lungs, our heart, or even travel to our brain. Again, some things just to watch out for with IVC filter placements is possible migration, possible air embolism, improper placement or perforation of the vena cava, and they may need to replace these filters. So if there's a patient that is having a lot of clot filled up or back up, and it's even clogging up the filter, they may need to have to replace them. So how would we prevent this? So we want to prevent clots as nurses, right? What would you do as a nurse to prevent DVTs? Early mobilization, early ambulation. That's so important. If they're bed rest, what do we want to do? We want to turn and reposition, right? We want to get them out of the chair for meals. If they can get up, anytime that they can get up and moving, we need to do it. Always keeping their SCD boots on, okay? Those are the sequential compression device boots. TED stockings, making sure that they're on anticoagulants like heparin or Lovenox. Even patients who are not in for clots, if they buy themselves an admission, they typically buy themselves a sub-Q heparin injection along with it. And if a patient has, a DVT, nursing care that we want to do, okay? So if they are on anticoagulants, what do we need to watch out for as nurses? So first, monitoring our vital signs, right? So if we have any active bleeding going on that we can't see, what vital signs do we want to look out for? Hypotensive, tachycardic, they show kind of signs of being shocky almost, okay? So that's, if they're losing blood, they'd be hypotensive and tachycardic. We want to look for blood in our urine and stool, okay? How's their skin looking? Are they having increased bruising? Are they having hematomas? Is there sites that they have like IVs in? Are they bleeding around their IV sites? Labs, right? We want to monitor their labs, their, CBCs, their coags. To the best of our ability, we maybe avoid any IM injections, okay? Minimize any venipunctures, using small gauge needles as necessary. Um, electric razors are better than just straight edge razors, right? We want to be careful with shaving. Teaching the patient not to forcefully blow their nose, using humidified O2. We know oxygen dries out our nares and we can create nosebleeds. So, especially if a patient is on anticoagulants, we do not want an increased risk for bleeding in that manner. So adding humidity to the O2. Education on soft bristle toothbrushes. Do not vigorously brush their teeth. I think I said not to forcefully blow your nose. Being careful even with tape application, especially if the patients have more of a thinner skin. Being careful with taking the tape off. Even stool softeners, we don't want patients straining, right, for stool, so giving them stool softeners. And also, teaching patients who are at risk for falls or families for patients who are at high risk for falls. They hit their head. We just do not want any intracerebral hemorrhage going on or any other trauma. Continued care for DVT. So we're teaching patients to prevent further DVT, how they can prevent any DVTs further, okay? So this is probably more discharge instructions, making sure to administer the prescribed anticoagulants, whether it be by mouth, sub-Q, or IV, monitoring our appropriate labs, again, our PTT, INR, H&Hs, assessing for severe complications. That can be what? Like a PE, right? So we want to assess signs and symptoms for PEs. Safety precautions on preventing falls is huge. If they are placed on Coumadin, dietary guidelines to follow, especially limiting the green leafy vegetables. If the patient's traveling, what education do we want to do for patients who may travel a lot? Take breaks, right? You want to pump your feet, move your feet, go for short walks, maybe even wear a set of TED stockings if you're traveling a far distance. even avoiding any contact sports, sports for high risk for trauma. Do we place the sequential compression boots on the affected DVT limb? No, that can set that DVT off into our circulatory system, into our pulmonary system, and we may end up with a pulmonary embolism. Patient may need bed rest if necessary. That will be provider based. We just wanted to prevent any further clot dislodgement. It's okay to elevate the affected limb, but should pillows be placed under the knees of the patient? Yeah, no, probably should not. That's going to actually ensue more issues for clotting. Okay, so if we can elevate the bed instead of putting pillows under the knees, that would be the best case scenario. Again, providing fall education, and if there is any sort of bleeding, education on how to apply pressure to bleeding. If they're in the hospital and we take out, their IV well, we want to at least provide pressure for 10 minutes to the site after we've taken out a well or drawn blood. Okay, everyone, we're moving right along here to angina, a fancy word for chest pain. So, what causes a patient to have chest pain? So think about oxygen, right? And we talked a lot about PAD and our extremities being in pain because of decreased oxygen and blood flow. So it's the same thing going on with our heart, right? We're not getting good enough oxygen and blood flow to our heart. So our heart's going to kind of be screaming in pain, needing more oxygen, okay? And that causes the pain. Angina, again, it's chest pain as a clinical symptom of, myocardial ischemia. So again, ischemia is decreased oxygen and blood flow. What could cause a decrease in oxygen? So you told me very well in class. Again, we have narrowing of our coronary arteries by the atherosclerotic plaque. And for chest pain to occur from atherosclerotic plaque, it's usually stenosed at least 70% or more. This is a really good video. I want you guys just to really pay attention to about the 3 different types of chest pain that I want you to know. So just concentrate on the causes of this, what causes the 3 different types of chest pain, and kind of, the different symptoms of each. And moving on to this slide helps us out even more. So again, we have that stable angina that was talked about in the video. So again, this is from a fixed blockage of the coronary artery from buildup of cholesterol. Symptoms are typically, more predictable. And these symptoms come with exertion or stress, okay, and they go away with rest. And that's what picks apart the stable angina to the unstable angina. Over time, again, the blockage gets worse and symptoms may occur earlier and more frequent. And again, too much damage for far too long can cause an MI. And then we're moving on to unstable angina, which is more of an emergency situation. So as a previously stable blockage, it now becomes unstable and pretty much is, totally occluded. The symptoms don't get better with rest. The symptoms are very unpredictable, and it's very typical for a patient to have an MI very soon if they're having unstable angina. And then we move on to vasospastic angina. And really, typically there isn't an underlying blockage with this, but what happens is the vessel walls actually clamp down and squeeze off blood flow. So it's constricting, and it's spastic. It's vasospastic. Again, it's unpredictable. If it is prolonged and not corrected, it can cause a heart attack. We typically see this with substance use, tobacco, caffeine. Okay, our artery goes into spasm. And some precipitating factors of angina, again, in general, um, physical exertion. Okay, this is a big one for that stable angina, right? Even temperature extremes, you may never think about that, but actually our blood vessels constrict in relation to cold, and then they can dilate in the heat. So just those changes in temperature can have an effect of chest pain. Stress, emotions, it can manifest chest pain a lot. Consumption of a heavy meal, tobacco, substance use, sexual activity, circadian rhythm patterns, very weird, but we tend to see a lot of manifestations of like coronary artery disease and chest pain to happen early in the morning just after awakening. And it's really important to know our PQRSTs, right? This is really how we evaluate chest pain. So P, precipitating events. What caused this to happen? Was it stress? Was it exercise? Was it an argument? Did you have a heavy meal? Um, did you have caffeine? Any substance use? Okay, so precipitating events is a major, you know, thing to interview the patient for. Quality of pain, the Q. What does it feel like? Is it like a pressure? Is it dull? Is it aching? Is it sharp? Is it more heavy or tight? R, the region. Where is it? Where is the pain located? Is it substernal? Is it right chest, left chest? Does it radiate anywhere? Does it radiate to the jaw, down a certain side of the arm? Does it radiate to your back? Does it radiate to the neck? Severity, and you guys know this is, that 0 to 10 scale. How bad is the pain? And then timing. When did this start? Okay, is it getting better? Is it getting worse? Is it intermittent? Is it constant? And then these are just some common locations of chest pain. So, again, we have the upper substernal chest, substernal radiating to the jaw and neck, substernal radiating down to the shoulder and arm. We have epigastric pain. We just have neck and jaw pain, just shoulder and arm pain, and then actually like scapular pain. So just the reddened areas are all examples of where patients may find pain. I know, we hear a lot about when women have chest pain. Sometimes it's just like in the shoulder or arm or in the jaw. And a lot of times, what can be very dangerous about this is patients may chalk it up to like, oh, if it's epigastric, I'm just having some indigestion, or if it's just the arm or a neck, it maybe they're thinking it's more muscle than anything. So it's kind of scary sometimes that it's hard to depict whether if we're having chest pain or not, and when to come to the emergency room or not. Makes it hard for patients. It's always best to come in, get it checked out for sure. So we're going to talk a little bit about pharmacological therapies for chest pain first, okay? So I want to talk about the short-acting nitrates, and our most common first line of defense for short-acting nitrate is a sublingual nitro. It goes right under the tongue, and it should be relieving the patient's pain in 5 minutes, and it can last up to at least 30 to 40 minutes, hopefully. If it doesn't, we can repeat this order. Typically, an order is placed stating repeat every 5 minutes for a max of 3 doses, okay? Especially if pain is not relieved. If it's not relieving after the third dose, we probably should be contacting the provider, getting a little bit more pain relief, and probably a little bit more treatment to see what's going on and what's underlying this, okay? Because if it's not getting better with rest or nitro, we may be having a little bit more issue on our hands than we think, okay? Um, Longer acting nitrates. Okay, so these, reduces the frequency of angina attacks. So if we think about it, if we have that stable angina that can happen often, being put on a long-acting nitrate would be very beneficial to the patient. So the one I want you to know is Isordil or Isorsabide. Okay, so that's just going to hopefully cut down on the frequency of stable angina attacks for the patient. Also, NitroPaste is another long-acting, and it's a thick paste. It will go on a piece of paper. It's a rectangle type of shaped paper, and the order is typically for an inch of paste to be placed. And usually it goes on the upper body, like the upper chest, over like a flat muscular region. There really shouldn't be any hair. The area should be free of hair. And typically it's put on in the morning and it's taken off at night. When this is taken off, we want to make sure that we really cleanse the area down very well with soap and water. We don't want any excess nitrate to remain on the skin, so the patient has effects throughout the night. So we don't want that happening. It can typically drop a patient's blood pressure if we leave this on overnight or if it's not cleaned well enough. Let's see. We do want to just make sure if we're giving either a short-acting nitrate or a long-acting nitrate, it's really important to make sure that the patient doesn't get up too quickly, to monitor their blood pressure. Blood pressures can drop, so we want to be careful of that. And also getting up slowly. The patient can be very orthostatic, and they can have orthostatic hypotension. So we don't want the patient to be dizzy or fall. We just want to make sure that the patient is safe. So giving the patient that education on just getting up slow, making sure someone is with you. We may want to get a set of orthostatic vital signs. It's also important to know if a patient is going home with like the sublingual nitro. Once the bottle is opened, those tablets start to lose potency. So it's really important for the patient to change the bottles about every 6 months for the sublingual nitro. So these short-acting and long-acting nitrates, these really help dilate the peripheral blood vessels. They decrease any venous pooling, in any venous blood return to the heart, which means that the myocardial demand is really decreased and it takes off the workload of the heart in a great manner. So we're dilating the coronary arteries. We're increasing blood flow to the ischemic areas of the heart. Okay, so that's our major. That's really what we're working towards. We're dilating our coronary arteries. We're increasing blood flow to the ischemic areas of the heart. More on medication and pharmacology. So I know you've heard about ACE inhibitors. We talked a little bit about this in class. So angiotensin converting enzymes. These are very helpful for chronic stable angina. These help decrease endothelial dysfunction, and it helps vasodilation again. It helps bring the blood quicker to the ischemic areas and also oxygen to the ischemic areas. So ACE inhibitors, the prils, lisinopril or Zestril, Catepril, Ramipril, or Altase. Okay, so just know those three. And then we're also going to talk about the angiotensin 2 receptor blockers, or ARBs. And again, this is helping for vasodilation. And these are more so used in patients intolerant to ACE inhibitors. So ACE inhibitors are kind of more first pick. And if they cannot handle the ACE inhibitors for some reason or another, if there's some contraindication, then the patient may be put on a angiotensin receptor blocker or an ARB. And these are losartan or Cozar and valsartan and Diovan. And beta blockers, we know these. So the beta blockers are going to help reduce the heart rate and contractility. They're going to help decrease blood pressure a bit. They're going to help reduce ischemia. They're going to decrease afterload. And they're going to inhibit our sympathetic nervous stimulation of the heart. Okay, so they're going to do a lot of things. And the examples I want you to know of these are atenolol or tenormin, metoprolol or Lopressor, carvedilol or Coreg. Next, we're moving on to calcium channel blockers. So these will help prevent or control coronary vasospasm. So remember, what was the type of angina that was focused on vasospasming, or the Prinzmetal's angina, right? So if you think about it, this would be an optimal drug for a provider to put a patient on if they do have this type of angina. It's going to help promote coronary and peripheral vasodilation. It'll help reduce heart rate, contractility, and even blood pressure. And it'll prevent calcium entry into the smooth muscles, also known as the cardiac cells. So 2 examples I want you to know for the calcium channel blockers is diltiazem or cardizem and amlodipine or Norvasc. And we're going to talk about an opioid too. So, especially if the nitrate isn't working well for pain, sometimes patients can be put on an opioid along with the nitrate, and that would be morphine as the best choice medication for this, and it's an analgesic and a type of a sedative. It helps with vasodilation actually, and it will help reduce preload and myocardial oxygen consumption. So not only is it helping with pain, but it's actually working as a vasodilator. And if we remember the acronym MONA, morphine, oxygen, nitrates, and aspirin, okay? Still going with PHARM. So antiplatelets. So we really should be giving this, especially as soon as we think that the patient may be having an MI, especially if they're having that unstable angina going on. We really probably should be getting at least an aspirin. We typically have patients chew an aspirin if this is what's going on. These, of course, the antiplatelets inhibit platelet aggregation. And I know we've also talked about Plavix as well. Anticoagulants, especially if a patient is undergoing a mild MI or an NSTEMI, we'll typically see patients be placed on a heparin drip. Again, this is going to prevent any conversion of fibrinogen to fibrin. And again, heparin drip, IV, very common. And then thrombolytic is kind of the big boy. So if a patient is having a very bad MI, also known as a STEMI or an ST elevated myocardial infarction, we really want to be getting this patient TNK as fast as we can. Okay, and we'll get to that in a little bit, but it's actually going to break up any fibrin meshwork. It's going to dissolve that clot in a very quick manner, and that's given IV push. So nursing care, if our patient is having chest pain, what do we want to do? And I know we went over this pretty in depth in class, but first we want to really start ruling out any acute coronary syndrome, okay? Making sure we rule out any MIs that are going on. We can never assume, right? We can never assume if a patient's just having their regular stable angina. We should never assume that, okay? So what's one of the first things we want to do? So our nursing assistant comes out of the room. They say that your patient is having chest pain. Probably should go in with a vital sign machine, right? So we want to get a set of vital signs, make sure their heart rate, blood pressure, their oxygen levels, are doing okay. And after that, we probably just want to get an EKG, okay? That's very, very important. So getting a set of vital signs and getting an EKG is very important. We want to see if there's any changes or with ST elevation or depression and whatnot. So we want to rule out if the patient's having an MI, and an EKG will help us with that. We don't need an order for an EKG right away, and we don't need to wait for an order, okay? It's an emergency when a patient's having chest pain, so it's okay to get an order afterwards, okay? It's called an independent nursing action or an INA, and we can get an EKG immediately. Probably want to put some oxygen on our patient too, right? Okay, so get a little, more of a demand for oxygenation, put a little oxygen on our patient, help them out a little bit with the body receiving more oxygen to the heart. So as nurses, we're working to preserve the heart muscle as quick as we can if an MI is suspected. Think about patient positioning. We probably want to position them upright, right? So thinking about their airway, positioning the patient upright, putting a few liters on them, nasal cannula, supplemental oxygen. We have gotten that EKG. Probably want to start thinking of maybe some pain relief if they're having some pain. So, if we can get them sublingual nitro, that would be great. They may need some morphine. We probably want to tame some labs, right? And we'll get into some cardiac biomarkers in a minute, okay? And that would be our next step as well. So vital signs, EKG, get some oxygen on the patient, take a look at their pain, get some labs. We went over this chest pain protocol in class, but the major thing is getting that EKG as quick as we can. It's an INA. We don't need an order, so you can get one emergently. We can always get an order after. But this EKG needs to be read in 10 minutes or less, and it has to be signed off by the provider. Again, we just don't want to miss if the patient is having an MI, and this should be cutting down on any misses of MIs within the hospital facility. We should be leaving the leads on the patient if they're continuing to have acute chest pain. And the reason to that is that MIs can evolve, and we may see ST elevation or ST changes in the EKG maybe a little bit down the line if we keep those leads on, okay? So it's important until we figure out a plan or till the provider tells us to keep those leads on the patient, okay? Even taking pictures, if we press that print button, every 5 minutes, along with a set of vital signs about every 5 minutes as well, okay? And we just kind of went over the leads for the EKG for those of you who weren't too familiar with taking EKG. So this is a normal EKG. We have leads V1, V2, 3, 4, 5, 6. And we have our limb leads, okay? So right arm, right leg, left leg. And we talked a little bit about doing a right-sided EKG and the reasons for that. So really a right-sided is just the mirror image of the left-sided EKG. So leads V3, 4, 5, and 6 just head on over to the right side instead of the left. And they still do that crescent moon shape, but instead it would be under the right breast. And then we talked about the posterior leads as well. Okay, so doing a posterior EKG. So all it is leads 4, 5, and 6 become 7, 8, and 9 around the back of the scapula. And the reason we do this is because sometimes we need to see different angles of the heart. Okay, sometimes there's an MI happening more in the posterior extension of the heart. It could be more inferior, it could be lateral. So we need to make sure that we're getting a picture on all sides of the heart if it is suspected. And the providers are pretty good at telling us what to do, and they'll give us a verbal order if they do want another type of EKG. I just wanted you guys to know that there is such a thing and what it looks like. So if you do come across this, you won't you'll have a little idea about it. And then getting into the cardiac biomarkers. So we've talked about troponins in class, right? And this is the most common cardiac biomarker that is ordered on a patient, especially experiencing chest pain or for ruling out acute coronary syndrome or ACS. So same term, it's cardiac enzyme or it's a troponin. They're used interchangeably. It's a yellow top tube. And this is actually picked up. What happens is proteins get released into the blood from necrotic heart tissue. So if we're having injury going on to our heart, we're not having as much oxygen, and our demand for oxygen is higher, we're going to have these proteins released, okay? Our normal values are 0 to 0.04, and anything above that, we're starting to see some elevation going on. Troponins are typically ordered in a Q4-hour fashion, and we order them until we see peak. And I know we went over peak in class a little bit, okay? So we order them, they're done every 4 hours until we come off our peak, okay? So for example, we have a level of 1.14. And then we have a level of 2.20. And then we have a level back at 1.50. What is our peak? 2.20, right? And that will give us an idea of when we can stop taking the troponins. So we always just need to see that peak level, okay? I also mentioned a CKMB. Yes, these can be taken. They're not a great definitive measure, but they are a cardiac biomarker, so I did just want to include it in the slide. And these help quantify myocardial damage. So they're either labeled as 3 to 5% or 5 to 25 is the normal range. Okay, and if we see a rise in CK levels, we may be having some myocardial damage. Definitely less sensitive than a troponin, but again, I do want you to know about the CK-MBs, creatinine kinase MB. So that's specific to the cardiac muscle. And again, our presence of biomarkers, it really helps distinguish between unstable angina or NSTEMI, with what's going on. If we don't have any elevation at all, okay, we can say the patient is having stable angina and treat them from there. Or if we are having some elevation, it may signal to us that we are having some acute coronary syndrome issues, and we may need to treat this patient for a possible NSTEMI, okay? So more of a milder MI. And I just want to show you guys just a normal PQRST. So this is part of your rhythm strip that you're going to go over very soon. We have our P wave, Q, R, ST segment. And this is the one I really want you to focus on, because if we're having an ST elevated MI, this ST segment is going to be elevated. And it's actually going to turn into what is called a tombstone. If we look at this next slide, here we are here. We have our normal PQRST segment, and it's turning into an acute MI. We're having ST elevation, and it's looking like kind of like a tombstone marker, okay? I really don't want you to pay attention to like the hours, days, and weeks later. The purpose of this slide is to get you a picture of normal PQRST to an ST elevated PQRST, okay? So I just want you to see how that turns into that tombstone looking thing. And then just another example, this is actually an EKG print. So I'm sure you can pick this out, but in the specific lead of more on the right hand side of the screen, we have ST elevation. We have the tombstone looking ST elevated complex here. Okay, so I just want you to get a visual of what ST elevation looks like. And if we see that, that is a major emergency. So if we're just ruling out acute coronary syndrome, the patient's having chest pain and we're ruling things out, there's a few other things that we can do for the patient as well. So we can look at an echocardiogram. So it's pretty much just like an ultrasound of the heart. So it can rule out any wall motion abnormalities, if there's any filling defects or filling abnormalities, valve abnormalities. We can also do a stress test. It can be a nuclear stress test. So we just see how the heart reacts under exercise, under exertion, and sometimes maybe it can pinpoint if there is a certain blockage or not. But kind of our most definitive test, if we are ruling out for a blockage, is a cardiac cath. It's going to localize that coronary artery, and they're going to put a little bit of dye into that coronary artery via a catheter, and they're going to try to see if there's any blockage, and that dye is going to help us kind of pinpoint where the blockage would be. If there is a stent needed, then a stent could be placed. At Berkshire Medical Center, we do not place stents. We can do a cardiac catheter, but we cannot treat. We can diagnose, but we can't treat. So our patients would go to Baystate if they were to need a stent placement. So again, just a run through of unstable angina, ruling out acute coronary syndrome, and the steps that we need to take as nurses is we're getting, if they're having chest pain, we're going in, we're getting those vital signs right, and we're getting that immediate EKG, and we're having that EKG read in 10 minutes or less, and that EKG needs to be signed off on, okay? So once we know, which way to go from there, it's important to always make sure that your patient has IV access. Probably place a patient on some O2 therapy, some 2 liters of O2. Offer them some nitrates depending on the provider. So think about that MONA acronym. So we're giving some morphine, we're placing O2, we're giving nitrates, and we're going to give some aspirin, if not Plavix. Okay, we want to just thin the blood a little bit with that antiplatelet therapy. The patient may need some cardiac medications, so whether it is a beta blocker, ACE inhibitor, or calcium channel blocker, all that from what we talked about in the pharmacology section. Placing them on high dose statins. We talked about the statins in depth. And then this is cardiac recommended. They may need to go for a possible cardiac cath just to rule out if there is a blockage or not. Okay, so we're just talking about unstable angina, ruling out acute coronary syndrome here, and the steps of what we need to take. So we're getting into MIs now. So if the patient is positive for an MI, we're going to talk about an NSTEMI first, and this is more of the mild kind of an MI. NSTEMI means a non-ST elevated myocardial infarction. So there is a thrombus and there is a blockage, but it's not totally occluded. So the patient is still getting a little bit of blood flow. They're feeling the effects of it because they're still not getting that oxygen demand that the heart is needing, but it's not totally occluded, whereas it would be in a STEMI. You will not see ST elevated changes on an EKG, and that's what kind of helps us determine whether it's an NSTEMI or STEMI. Sometimes we may see ST depression, if anything, if it is an NSTEMI. So instead of that ST segment being elevated like the tombstone, it will be inverted. It will be inverted. It will be the other way, okay? Patients who have an NSTEMI, it's not an emergent thing, but they probably should be undergoing a cardiac catheter at the most 72 hours after diagnosis. Okay, so patients can get this done at least 12 to 72 hours after. We'd be finding a bed for them at Baystate, and we'd be transferring them out, but not as emergent as a STEMI would be. Thrombolytic therapy, like remember we talked about the big boy of TNK, not indicated for this, okay? Heparin drip, yeah, sure, but TNK, no, not for an NSTEMI. And then we're going into the STEMI here. So this is the emergency. This patient needs to be, especially if they're at Berkshire Medical Center or at a facility that doesn't do PCI, they need to be sent out immediately for catheterization and PCI placement. So this is an ST elevated myocardial infarction. It is caused by a totally occluded thrombus. So whatever coronary artery is occluded, it's not getting any blood flow whatsoever, and it's causing ischemia to our heart, and our heart is dying. So this is a medical emergency. If this artery is not opened up, the patient will die. So this artery actually needs to be opened within the 90-minute time frame. This is a presentation to balloon, okay? 90 minutes. And this is just to help to restore blood flow and oxygen. Thrombolytics like TNK. TNK is going to need to be given IV push, and the patient will need to be given a stent via catheter, cardiac cath. PCI will actually confirm which artery it is. It's by the dye, we're going to be able to see what artery is affected. and that balloon will go through via the catheter. It will open up that artery, and a stent will be placed. Typically, the stents are like a drug-eluting stent, so a thrombolytic medication is in, kind of intertwined into the stent itself to help aggregate any clots from there to further form around the stent. I just wanted to show you here, I don't expect you to know this, but just how the leads show the different types of MIs that can occur. So in the yellow, these are all the different MIs and the locations of them. So leads V2 to V4 can show an interior wall MI. Leads V1 and 2 can show a septal wall MI. Leads V5 and typically V6 are lateral wall MIs. Leads 2, 3 will typically show an inferior wall, and a posterior wall will be leads V1 to V4. Also, we talked about, remember, the right-sided and posterior EKGs leads can help us find more of a definitive measure for what type of MI is going on as well. So EKGs can give us a kind of a heads up as to where the MI may be, and that is why we do, if the patient is getting sent out to the cardiac cath lab at Baystate, we send our EKGs, we fax them to them, and it'll help them have an idea of where the MI may be depending on where the ST elevation is happening in the lead. Okay, so this depends on where the ST elevation is happening. So if we're seeing ST elevation in leads V2 to V4, we're probably having an anterior wall MI. Okay? And again, just the different locations of the coronary arteries. There's the right coronary artery, the left coronary artery. We have the circumflex branch that branches off of the left. We have the anterior intraventricular branch that also branches off from the left. Okay, so just a visual of what the coronary arteries look like around the heart. So STEMI and STEMI protocol, okay, and I know we went over this in class, but again, a STEMI is abrupt stoppage of blood flow through a coronary artery, and it's causing necrosis and death to our heart muscle, and we need to reverse this immediately and open up the coronary artery for the patient to survive. So it's treated as an emergency, it's impending death. So we went through this whole sheet of, determining whether it's an NSTEMI or STEMI, and that's what we do pretty much with our chest pain protocol, right? So this is why we have to have the provider read this off in 10 minutes or less to determine if it's a STEMI or NSTEMI. And we need to put our EKG time on the STEMI protocol and also when this was determined by the provider. So both of those times will be placed on the sheet. We need to emergently call Baystate. Okay, so I know there's Baystate numbers on the sheet that we went over. There's weekday numbers, there's holiday numbers, and there's weekend numbers. And remember calling them that it's only a 9-digit, so don't put the 1413 as a callback. It has to just be 413-447-2330. Okay, something like that. They have to call you back in 2 minutes or less. Okay, you get an automated system when you call, and then it alerts someone, and then they will call you back. The provider will want the EKG faxed to them at Baystate. We have to call pharmacy for a heads up because if the patient is eligible to receive the IV push TNK, they need to know the weight of the patient and they need to mix the drug immediately to bring it up to you. We also need to call either Action Ambulance or County. They both have a special STEMI team that will come and transport the patient whether they are stable or not. And remember, we talked about this in detail in class, that a patient, whether they are stable or not, needs to be sent out. If they stay with us, the end result is death. So I mean, whether or not they're coding, typically, if they are having a STEMI, they are at huge high risk to code. They need to take them. And I remember, just remember the story I told you about the patient that was on tele. He actually started to code after we were starting to treat him, and the EMS team was able to take him all the way. They put him on the Lucas machine, which is a CPR machine in the ambulance. They brought him into the cardiac cath lab. They cathed him. They put a stent in. They opened up his coronary artery, and he was actually, when we went and asked about how he was doing the next day, he was actually, they were taking him for a walk around the unit. So a lot of providers are still confused with the fact that the patient may need to be sent to the ICU. They need to go. They need to leave whatever unit they are on and go. Okay? And if there's one thing you remember from this, is that they need to go. Okay? Also, I just want to see if I'm missing anything from this. Of course, oxygen needs to be applied to the patient. They should probably be put on the pads just because there's such an increased risk for cardiac arrest. The arrests that patients can go into if they're having a STEMI are ventricular arrests. So that is either pulseless VTAC or a VFib arrest. So anything ventricular, patients with ST elevated MIs go into ventricular arrests. A MET team does have to be called for a STEMI, so that's one of the first steps as well. As a MET team, the charge nurse from the ICU will come down. Hopefully that TNK will be mixed very quickly, and the charge CCU nurse will push that IV TNK very fast. We do tend to see, especially when the patient becomes revascularized, we see the patient can have revascularization like rhythms. Okay, so they may be going into some different rhythms, but the EMS team will be able to treat those from there. They typically see this about halfway to B state. If TNK is pushed at BMC, they'll start to see revascularization about halfway from what I've heard from them. It's always important to go over the contraindications. Sometimes not all patients can get TNK. So did they just have surgery? Did they just have a stroke? Have they had a head bleed? I also went through an example. I'm not sure if I told this in class, but I was charged on the CCU again, and it was the evening shift, and they were working with a patient who was on rehab in the gym. He became severely diaphoretic, had sudden chest pain. They brought him back to his room. He had a stroke maybe about a week ago. So he was getting PT done because of the stroke. Unfortunately, he wasn't, able to get the TNK. Unfortunately, this patient passed away on us. He coded, and this one really wasn't a well thought out transfer. Providers wanted him to stay here. It's still very confusing to providers. So if we, if anything, as nurses, know that we need to get the patient out, call EMS, call Baystate. That is so important. Okay, and I would be so thrilled that you guys carry this with you in your practice. When we call Baystate, they are our provider now. So we take orders from them. Okay, so once we call Baystate with a STEMI, we listen to them. They are our cardiologists now. Okay, so if you can think about it like that, that might be probably the best way to think about it. And I think that's all as much as I want to get into STEMI with you on this voiceover. Again, we talked about TNK. So again, it's only indicated for patients with a diagnosis of STEMI, and it's really going to help us restore perfusion, and it's going to break up that clot very, very quickly. It's going to dissolve that thrombus, and that's given IV push very quickly through the IV. We always need to be aware of contraindications. We'll go over some of those on the next slide. And why do we want to monitor for mental status changes? If for some reason the patient does develop a head bleed of any sort because of the TNK, it's really important to check their neurological status, do some neuro checks with the patient after giving the TNK. And again, what should we expect when reperfusion happens? And we went over this a little bit in the last few slides, but we can have reperfusion dysrhythmias or arrhythmias, and again, pretty easy to treat by ACLS medications. Either the nurses or EMS can treat reperfusion dysrhythmias. The patient can actually start to be more alert. They may have relief of some chest pain. They're going to feel a little better. And these are just some absolute contraindications, meaning they can absolutely not have TNK. So any prior intracerebral hemorrhage, known vascular lesions, hemorrhagic stroke, any malignant neoplasms or malignant cancers, tumors in the brain, if they've had an ischemic stroke within 3 months, any suspected aortic dissection, active bleeding, excluding menses, of course, significant closed head or facial trauma within the last 3 months, intracranial or spinal surgery within the last 2 months. So these are all gone over with the provider in detail, especially, quickly, because we're getting the patient out. The patient needs to be out the door in 30 minutes, okay? If I didn't state that in the slide, we talked about the STEMI protocol. The patient needs to be out the door in 30 minutes, just to get to Baystate for best practice treatment for them, okay? So this is all happening in a very quick manner. And then relative contraindications are things that maybe they can have TNK, but again, that's provider specific. And again, we're dealing with the Baystate provider, so that's going to be their choice on whether or not they want them to receive the TNK. I'll let you go through the relative contraindications on your own. And then the whole reason why we're getting to Baystate is this cardiac cath, right? We need a stent placed, and we need the patient to have revascularization and to open up their coronary artery. So again, for NSTEMI, it's not as emergent. It can be 12 to 72 hours. STEMI, it is emergent. So door to balloon time is 90 minutes. Okay, so from onset of symptoms to get to Baystate is 90 minutes. Patient needs to be out of our door at BMC in 30. Okay, we've done it before. It's just the emergency room does it wonderfully. They're like a well-oiled machine. EMS notices ST changes on their EKG. They wheel them in typically to trauma bay 1. They push the TNK, and they're out back the door to Baystate. Whereas if patients are inpatient, it's a little bit more detailed, okay? It's not common, so it's not like we're practicing this all the time, but we try to do a lot of drills and try to get nurses, more educated on the STEMI protocol. So we try to get these patients out in 30 minutes. We're trying to preserve the heart muscle as best as we can, and we're opening this occluded artery by cardiac cath and placing a stent, and drug-eluting stent is inserted into the blocked artery, and we're going to have some pretty fast reperfusion. So these are all videos of a cardiac cath with a stent. And just another photo here of what a stent looks like, the stent delivery, how it balloons open, and the stent stays in place after the catheter is removed. All right, and then the last thing I want to talk about is cardiac arrest, and I'm sorry we didn't get to this video in class, but I really, really want you to watch this on your own. It's really important, and a really important piece of information for your exam. So cardiac arrest is a patient isn't breathing, okay? So there's an absence of pulse, there's an absence of breathing, patient is dead, okay? So, we need to help bring this patient back. And it's from an electrical problem within the heart. And the common arrhythmias that cause cardiac arrest is asystole, PEA, also known as pulseless electrical activity, and I know we went over that with our PE content because that's the most common type of arrest that can happen for patients who have a PE. So asystole, PEA, pulseless VTach, and VFib. So those 4 rhythms. What is the single most important thing in cardiac arrest? And you guys were wonderful in telling me this, and that is CPR. Compressions, okay? I know we think of airway first with arrest, but we need to do compressions. The heart muscle is more important than anything, okay? It used to be airway, breathing, circulation. Now it's CAB, circulation, airway, breathing, okay? So think about CAB. We want to get on that patient immediately doing CPR, okay? So depending on the rhythm, early defibrillation is also important. So along with CPR, if it's a ventricular rhythm, such as a pulseless VTach or VFib, we need early defibrillation as well. So we need to get the pads on the patient very, very quickly, and we need to defibrillate the patient if they're in a ventricular rhythm as quick as possible. Research has shown that with early defibrillation, it will save the patient. It helps in mortality rates even better. And again, what rhythm should we shock? And like I said, it's pulseless VTach or VFib, any ventricular rhythm. And just a few things that we went over in class, just to reiterate. So how long do we determine unresponsiveness? And that should be 5 seconds. How long do we check for a pulse? And that should be the carotid pulse. 10 seconds. Compression to breath ratio should be 30 to 2. Okay, 30 compressions, 2 breaths. The compressor will stop or just take a very, very quick break with a breath. If the patient is intubated and has an endotracheal airway, we do not have to stop with compressions, okay? If they do not have an airway, we do have to give a little break to give that breath. Our compression depth should be 2 inches, and we should have a rate of at least 100 to 120 per minute. Chest recoil is so important. It helps that the pooling of blood. We need to come almost totally off the patient's chest and come back down. Okay, we shouldn't stay on that patient's chest. It's kind of hard to explain in a voiceover, but we need total chest recoil to get back on and continue CPR. Okay, so that's best practice CPR is chest recoil. How often do we take a break for CPR compressors? Should be about every 2 minutes. So it's actually when you do your pulse check, we should switch compressors, okay? It is tiring. And you know what? Think about the patient's life. So if our compressor is getting a little tired, do you think they're going to be doing the best CPR? Probably not. So we need to take the breaks. It's best for the patient. I know we really want to help the patient out, and some people don't like to take breaks, but we have to. It's impossible to maintain that strength and rate for more than 2 minutes at a time, okay? Where do the defib pads go? High right, low left. So remember that heart sandwich. So high right pad, there's going to be a low left pad, and we put that heart in a heart sandwich. I think we said this before, but how often do we reassess our rhythms? That's every 2 minutes. Again, that's when you can switch compressors for breaks. While the defib thing is charging, so if you're going to give the patient a shock and the thing's charging up and it's kind of doing that scary little charging up, should we stop CPR? Absolutely not, no. The noise sometimes scares people and makes people stop doing compressions, whereas it's just the opposite. We want to be on that chest as long as possible. The only break that we want to do for chest compressions is when, of course, we're shocking and when we're just assessing their rhythm, okay? And that's not long at all, not long periods of time. So while it's charging, yes, we should be doing CPR. Before we shock, we should say clear, okay? Especially, some people have even just had the sheet touch a jacket or a part of a scrub, and they have gotten electrical impulse right even through a sheet. So we really need to back off away from the bed. Just be very careful with with the electrical part of this. And of course, just talking about airway, in our hospitals, we have bag masks. Um, I'm not sure if you've gone through the emergency cart, maybe with either your clinical educator or someone there with you in the field. But an ambu bag with mask or a bag mask, same thing. They're on every emergency cart. We do not do mouth to mouth. We do not have special mouthpieces. All bag mask. It gets plugged into our oxygen on the wall, and the oxygen goes all the way up to 15 liters. Okay, so all the way up with the oxygen, it will inflate the bag that is part of the ambu bag, and then you'll be able to give proper breaths from there. Okay. And that is it, guys. I want you to watch, all these videos are so important within the PowerPoints. Any questions at all, please feel free to email me or use my office hours. Happy to help answer any questions. I know this is a lot of content. It's heavy content, but I want you to get this. It's interesting and it's important for your practice. So thank you all for listening, and I'll see you all soon. Thank you.